If you're grade 1 and
Right.
it resolved, you can rechallenge.
Yeah.
ILD management, how do you currently approach that?
Yeah, so, we follow kind of the 5 S's, right? So it's important to really inform the entire team and the patient being
Yeah.
the key in the team about watching for any types of symptoms. But obviously, when we have symptoms, that means we're at least grade 2. And so it's really going to be important to screen. And so I do tend to get pretty regular serial CT imaging of the chest and monitor very closely. And then if we do have just radiographic findings, then I stop, and I tend to start steroids pretty promptly. I think the faster you can allow it to resolve, the faster you can get patients back on therapy, and hopefully prevent, delays and other issues. And so, I've participated in a lot of the T-DXd trials, and so I usually follow kind of what the protocols called for. So less than 28 days, resolution. I'm usually getting a scan at like 2.5 weeks, 3 weeks. That way I can, act in between until early. And then, seeing where things are, and then rechallenging and following patients very closely. I've had certain situations where there's enough ground glass opacities that I may actually, when I rechallenge with a little bit of prednisone on board. Not necessarily for everybody, but I have considered that for some. And then, follow those patients. If it takes longer and it does eventually resolve, then I will dose reduce.
Right? What do you do in terms of frequency of scans?
Yeah. So I do tend to do it every nine weeks. Every 6 weeks is a lot. Patients feel like they're constantly going to the radiology department. I know most of the studies did every 6 weeks. So every 9 weeks over time, although when we look at the prior T-DXd trials, it can be that first year where it can develop, right? So you're not off the hook. In some situations, we may go to every 12 weeks, but again, we're following patients very, very closely. What about you? How often do you scan?
I tend to do at least for the first 6 months.
Yeah.
So 6 to 12 months is sort of where we see most of the T-DXd happening. So I tend to do Q6 weeks. I have to agree, it's hard for patients to come in and do that.
Yeah.
And then
over time.
depending on my concern, at 6 months I could spread it to every 3 months, or 9 weeks to 12 weeks, or wait at 12 weeks to spread it out. But I try to do it a little bit more frequent up front for the main reason you mentioned it earlier. If you're grade 1 and it resolved, you can rechallenge. And we found from data that's been presented that I think at ASCO, Perigo presented rechallenge, where most of those patients who were grade 1 when you rechallenge never have it come back. Which otherwise, if they were grade 2, although she had a small cohort who was grade 2, but current standard is you don't rechallenge that population. But if you don't get it at grade 1, then those patients then lose the ability to get this potentially life-prolonging medication. So that's how I do mine.